Good morning to everyone. I want to start by saying that I'm sick. My neurons are in hibernation, so I'm going to be kind of slow, and if you guys notice that I say anything that doesn't make any sense, I apologize beforehand. So yes, this morning we're going to be talking about short stature and failure to thrive. It is one of the topics within the endocrine field that we see most kids for and we get most referrals for, along with, I guess, diabetes. So it's obviously something that, it's important to understand from a general pediatric standpoint what is normal growth and what are the things that may be steering away from that normal growth and when to refer these kids to us. So I have nothing to disclose. I want to start by showing you guys this. The little guy on the left side, I guess right-hand side for you guys, is Moxie Bogues. He was 5'3". He played in the NBA for 14 seasons. He was part of 4 teams within the NBA. And he was defined as an spectacular passer. He was one of the faster players in the court. He was very successful. So this comes to tell you that success is not defined by adult height. And I know that in the current society, sometimes we do pay a lot of attention on those specifics, and some families have expectations for their kids that are kind of like within that tubular thinking of how tall they will be. But again, the same success is not defined by I guess how you look or how tall you are. And anyone can be very successful despite being short. The objectives for the talk will be pretty much about growth, normal physiology of human growth and development, discuss what are the normal variants of growth, which actually, and this probably is going to be the positive and reassuring comment of this talk, is that most of the referrals that we see for short stature are kids that have either a normal growth variant or kids that actually may not have any growth problem. So that in itself, it's good. So we're going to talk about those normal variants. We're going to talk about the endocrine and non-endocrine disorders that can cause short stature. We're going to talk about the initial screening labs that we recommend for a kid who's being evaluated for short stature. And briefly at the end, I'm going to touch base on the concept of failure to thrive. So the next few slides are about how do we grow. This first slide is about physiology of growth. And just briefly, this is a very simplistic model because we not only grow by growth hormone, there are many other factors that are actually important for growth. But just to show you in a general sense, I guess because the talk will or a big part of the talk will be talking about growth hormone. You guys can see on the diagram that basically we have the growth hormone releasing hormone being basically secreted from the hypothalamus. It goes to the anterior pituitary, where we have most of the cells there are somatotrophs that make growth hormone. Growth hormone is then produced and released. It goes to primary target organs, as you guys can see, liver, bone, and it has also primarily functions in other organs like the adipocytes and the muscle. And then from there, especially from the liver and from the bone, growth hormone then stimulates the production of IGF-1, insulin-like growth factor 1, which then stimulates the growth effects at the level of the bone. As far as like how do we grow from an auxological anthropometric standpoint, this is important to understand. And one thing that I want to make a specific comment on it is that I'm going to give you guys averages. I'm going to give you guys sort of like standards, but this is not just an absolute number. Remember that the general population is distributed in a kind of like Gaussian bell curve. So remember, there's going to be extremes that may be out of the normal distribution, but still be normal. The 2 periods of life where we have the highest growth rate or the fastest growth velocity are the first 2 years of life and when we hit puberty. So as you guys can see, the first 2 years of life, from birth to like 1-2 years, we're going to be growing at about 10 inches per year, especially the first year, 25 centimeters per year. Between that first birthday to maybe 4 or 5 years of age, the growth velocity is still, a little bit, faster, that growth rate, about 4 inches per year. And then usually between the 4th, the 5th birthday until we enter puberty, the growth velocity is going to stay at about 2 inches per year, more or less 5 centimeters per year. So again, that is an average. Some kids may be growing a little bit slower than that. Some kids may be growing a little bit faster than that. The next slide, I'm going to show you that there are 3rd percentiles and 97 percentiles for that growth rate. So just have that in mind. So this is showing you the normal height velocity for American boys and girls. On your left side, boys; on your right hand side, girls. And as you can see, this is starting at age 2. So you can see that after age 2, until you hit puberty, there's going to be sort of like a little bit of a growth deceleration. And again, remember that there's always going to be a 3rd percentile, a 97 percentile. So there's going to be kids that, despite growing a little bit on the shorter side, are still growing fine within what is expected for growth velocity based on age. You guys can see that once you enter puberty, you're going to have, or during puberty, you're going to have that growth spurt. Remember that girls usually have the growth spurt during earlier stages of puberty, tender stages. And then boys usually have the growth spurt later in puberty. So, a lot of the times I have kids that, between siblings, they're comparing, the 13-year-old male with the 11-year-old girl. She's taller than him. So, it's just a matter of obviously reassuring the family, explaining these kind of like concepts to the family, letting them know that, yes, usually girls will grow first compared to boys. Now the next few slides are about how we measure growth, because it is important. It is important to know what we're looking for and trying to do it as accurate as possible. Kids that are less than 2 years of age, we recommend that they are measured on a rigid table. The kid is going to be supine. There's going to be 2 boards. The head of the kid is going to be towards the rigid board, and then there's going to be a moving board that will be adjusted based on the kid's legs. So it's important to make sure that the legs are extended, the feet are parallel to the moving board. So that will give you the most accurate measurement for growth in kids that are less than 2 years of age. And then we have the stadiometer, which is for the standing up. Basically, the kid is going to be standing up. It's important that the kid is positioned in an anatomical position, that the kid's back, hips, and feet are actually all the way towards the board. And we typically like to get at least, or to get a total of 3 measurements, and you can average those 3 measurements and then go by that average, because there can be even inter-observer variability when you're measuring height. So it is important, as I said, to at least get 2 to 3 measurements and average those measurements. Not only getting 1 measurement, it's appropriate. These are the growth charts for kids that are from birth to 2 years of age. These are the WHO growth charts. These are more updated compared to the CDC growth charts for this age group. So they include a more heterogeneous population. And as you guys can see, the first 2 years of life are, growth velocity, as I showed before, it's it's one of the fastest one, especially during the first year of life. And then we have the CDC growth charts for kids that are 2 years and above. This goes all the way to 20 years. And these growth charts basically show you the exponential growth rate until you basically hit puberty, or during puberty. Then you basically once your growth plates are closed, then you stop growing. These are very important. Obviously, this is paper growth charts. We do now have that in Epic, but basically they're the same. And it basically is your tool to assess growth. So you want to look at it, you want to see, I'm going to show you what other measurements of growth we get, but you want to see, how the kid is growing, if the kid is basically tracking along, decent percentiles, if the kid is short, if the kid is crossing down percentiles of what is happening. And you can see also from the growth charts that typically girls actually have that plateau of growth earlier, usually by age 12, 13-ish, compared to boys that usually have the plateau later, usually like around 15, 16, sometimes even later than that. So what are the other things that are important to have into account when we're measuring growth? One of them, which is going to be very important to determine whether the kid is growing within their genetic potential or not, is going to be the mid-parental height. As you guys can see, there is a formula for girls, there's a formula for boys. So for girls, 13 centimeters is subtracted from the father's height, and that is average with the mom's height. And then for boys, 13 centimeters is added to the mother's height, and then average with the father's height. And that is important to plot on the growth chart as well, because then, as I said, it allows you to see how far away from that genetic potential the kid is growing and whether you should be concerned or not. Not all the time, if the kid is growing far from that potential, that may necessarily indicate that there is disease, as we're going to see when we talk about the normal variance of growth. And again, that is usually, it's important to explain to the parents that that is actually a calculation, is not necessarily completely accurate. It has a margin of error. So we do talk about the third and the 95th percentile within that calculation, which is usually more or less 2 inches plus and below that number, to also let the families know that the kid is not expected to actually grow exactly to that number. It is important to also measure proportionality, because you do want to see what is the relationship between the kid's height and weight. You do want to see what is the also proportionality in their body size, body proportions. So for kids that are less than 2 years of age, we use the weight for length to see, what's the correlation between weight and length. For kids that are above 2 years of age, we use the body mass index. And from there you can start seeing whether the problem is more nutrition, the problem is more about weight gain rather than actual short stature or poor growth. We do have 2 measurements of body size proportions. One is the upper segment to lower segment ratio, which is usually measured, so you will measure the lower segment from the top of the symphysis pubis to the plantar surface of the foot, and then you basically will subtract that from the height. The upper to lower segment ratio, so typically the younger you are, the ratio tends to be, your upper segment tends to be longer, but the older that you get, your lower extremities will start getting longer, so the ratio tends to actually start getting narrower and kind of like getting to like a 1-to-1 ratio the older you get. So it's important in certain situations where you may suspect that there is going to be some limb disproportionality. That will give you kind of like a sense of whether the kid is growing well or not from that reference. And then the arm span is measured from the tip of the middle finger on one end to the tip of the middle finger on the other end. And usually the arm span tends to be shorter the younger you are, and then the older that you're getting, the arm span starts getting more closer to match your height. And actually, usually when you have completed puberty, or like in adults, the arm span may be actually a little bit larger or than your height. But again, it's another important aspect when we're measuring growth to make sure if we're seeing proportionality between this type of reference, or if not, then to start thinking about what else can be causing this kid to be short. The skeletal age or bone age, you guys use it all the time. It's an important tool to measure growth. As you guys know, the bone age basically shows you how mature the bones look compared to the chronological age. So you can have a kind of like a sense whether the bones look concordant with the chronological age, delay, or advanced compared to the bones at the chronological age. And it is an important tool for us, as I'm going to mention, because it allows us to have also kind of like a presumption of what the adult height for the kid will be, and if that adult height will be within the genetic potential for that kid. And obviously in some growth disorders, especially the ones that are endocrine, growth hormone deficiency, hypothyroidism, we can see significant delay on the bone age as well. One caveat to bone age, it has certain challenges. Kids that are less than 2 years of age typically would require a hemiskeleton bone age, so we try not to do that. I mean, it's really impractical. From 2 to 5 years of age, it is not a good predictor of adult height. It tends to get better at predicting adult height the older you are. So, I mean, typically that would be helpful only to see if it's significantly delayed and you may be suspecting some pathological cause of the short stature. But again, for prediction of adult height, it gets better the older that you get. What is the technical definition of short stature? So technically, by definition, you're short. If your height for age and sex is 2 standard deviations below or 2 standard deviations or more below the mean for the age and sex. So that's important to understand when you're looking at your growth chart. EPIC now gives you the C-score or whatever your electronic medical record is. For example, EPIC gives you a C-score, so the C-score is basically how many standard deviations you are below the mean. So if you are 2 or below, that is considered short stature. For practical terms, it has been defined that a height that is less than the 2.3rd percentile is considered short stature. All right, so we talk a little bit about what is normal growth, how do we measure it, how do we grow, and then so let's now switch gears to what are the normal growth variants. We typically talk about 2, the most, I guess, common normal growth variants. I'm going to mention a third one that sometimes we don't talk a lot about, but it's also important. But the 2 ones that we talk all the time are constitutional delay of growth and development and familial or genetic short stature. So what is constitutional delay of growth and development? So these are kids that are basically growing on the shorter side of the growth chart, but they actually have a normal growth rate. They're showing you a normal growth velocity. Again, there can be some fluctuations within their growth velocity, but the overall growth velocity is reassuring. When you get a bone age on these kids, they typically will have a delay that may not necessarily be too concerning, so kind of like a delay that is still decent. And when you actually calculate what the predicted adult height for these kids will be, they actually will end up growing closer, right at, or within their genetic potential as defined by the mid-parental height. These are kids that are otherwise healthy. This is usually a normal variant of maturational tempo. So you want to make sure that you explain this to the parents, you show them in the growth chart, you know, what are the expectations. These are kids that you also should talk to the parents about the fact that these kids usually will start puberty also a little bit on the late side, so that they understand what are the expectations for growth and development of puberty. But as I said, these are kids that will attain a normal adult height. This is how the growth chart for constitutional delay of growth will look like. You can see these are kids that during childhood are growing on the shorter side of the growth chart, but then eventually when they enter puberty, they will have a nice robust growth spurt, and they will end up catching up to their genetic potential. Genetic or familial short stature, the name says it all. These are kids that are healthy, that are growing on the shorter side of the growth chart. but they are basically expected to end up within their genetic potential. These are kids that when you do a bone age, the bone age typically will be concordant to their chronological age, and the expected or predicted adult height, as I said, is very close to the midparental height. They will have a normal growth velocity, and the onset of puberty for these kids is usually within the right time. So this is a growth chart for a kid with familial short stature. You can see the kid has always been short and is expected to end up at the third percentiles on adult height, but that is within his genetic potential. And the third normal variant of growth are kids that are born SGA, small for gestational age. These kids can actually grow relatively shorter the first few months of life, but remember that the expectation is that these kids will typically catch up within the first 2 years of life. So sometimes it's just a matter of time, sometimes it's just a matter of observing their growth velocity. It should get better. Yes, there are some kids that will not catch up, and there is a different approach to those kids. There's indication for treatment of those kids, but really most kids that are born SGA will catch up within the first 2 years of life. These are all the causes of pathological reasons for short stature. I won't necessarily discuss each of them. Within the endocrine disorders, the one that I guess would be more common would be growth hormone deficiency and hypothyroidism. We do see Cushing's syndrome, but rarely. It's not really that common in kids, but it is there. These are kids that usually will have a poor growth velocity, but they will have significant weight gain. Precocious puberty, these are kids that we don't necessarily see when they're short. We actually see them when they're tall or growing too fast, and they're having obviously early signs of puberty, but some kids actually, if they were untreated, can end up being very short. Systemic disorders are very important because they do account for a good percentage of kids that are showing poor growth. So it is important that you guys understand, that the evaluation of a kid with short stature does look thoroughly for other causes of short stature. Any type of disease, really, immunologic, rheumatologic, GI, chronic steroids, undernutrition, genetic syndromes, which I'll briefly talk about, but a lot of genetic syndromes can cause growth retardation, but the ones that we typically see more commonly are the ones listed here. And skeletal dysplasias are, again, not very common, but things to think of. The initial diagnostic approach, as you guys may already know, includes looking for those systemic disorders and also looking for primarily what the most common endocrine causes of short stature are. So we want to get a complete cell count, looking for anemia, abnormal white blood cell counts, abnormal platelets, ESR for chronic inflammatory conditions, a comprehensive metabolic panel to look for your renal function, your liver function, your electrolytes, free T4 TSH to rule out hypothyroidism, IGF-1 and IGF-BP3. I wrote in parentheses as needed for IGF-BP3 for a few reasons. IGF-1 tends to be low in the first 2 years of life. That is normal growth physiology. So in practical terms, it's not necessarily very practical to measure it during the first 2 years of life, and it can also be affected by nutrition status. So some patients that are undernourished may have lower IGF-1 levels, so IGF-BP3 tends to be a better indicator or a screening lab in those kids under those situations. TTG, IgA, and IgA for celiac screening, and then bone age, as I mentioned before. Growth hormone deficiency, the name pretty much says it all, but one important aspect of it, as I said, growth hormone is not a major determinant of role the first 2 years of life. So in the neonatal period and the first few months of life, the major feature actually of growth hormone deficiency is hypoglycemia. Actually, those kids don't tend to necessarily show significant growth retardation during the first 2 years of life. In childhood, it's more the kid that is short, or kids that are basically crossing down percentiles, not growing the way they should. It is important that you rule out a normal growth variant. As I mentioned before, they will have significant bone age delay. Their IGF-1 level is going to be low for their puberty, and for their age and puberty status. And then it's a little bit out of the scope of the talk, but if you end up doing dynamic testing to rule out growth hormone deficiency, it is usually a kid that will have a peak growth hormone level during dynamic testing that is below 10 micrograms per liter. These are fraternal twins. The twin on the left has growth hormone deficiency, so you see how he compares shorter to his twin. And this is a growth chart of a kid that was diagnosed with growth hormone deficiency, started growth hormone treatment, and actually ended up attaining an adult height that was closer to his mid-parental height. Super quick, because these are really rare. There are growth hormone insensitivity syndromes where you pretty much have some degree of growth hormone resistance or intracellular signaling, I guess, malfunction that doesn't allow the processing or synthesis or function of IGF-1 to go as it should. These are kids that are usually IUGR, have extreme short stature. Some of them may have insulin resistance, and for these kids, actually, the treatment is not recombinant human growth hormone, it is actually recombinant human IGF-1. Hypothyroidism, I guess easy to catch in the sense of like it's part of the screening labs. The kid will probably have some of the other symptoms, but yes, poor growth is one of the main features of hypothyroidism, especially in kids that are severely or more profoundly hypothyroid. Some of the other clinical symptoms that you guys pretty much know: delayed dentition, thermic instability, constipation, dry skin, slow reflexes, brittle nails, some of the things that you guys already know. These are kids that actually can have also a significantly delayed bone age. And I guess a brief comment on that: usually when we start treating these kids, we try to start lower doses of the thyroxine replacement to avoid advancing the bone age too rapidly. One thing that is important is the thyroid is very important for the release and effect of growth hormone. So if you have a kid that is hypothyroid, you're more likely to have a low IGF-1. That kid may not be growth hormone deficient, so it is important that you treat the hypothyroidism first, see how the kid is growing. If you're still concerned that the kid is not growing well despite normalizing your thyroid labs, then you can go ahead and do or repeat your labs to rule out growth hormone deficiency, but it is very important that you treat hypothyroidism first before determining that a kid has growth hormone deficiency. This is the growth chart of a kid after thyroxine replacement was started. You guys can see the kid was very short, and then once thyroxine replacement was started, the kid actually grew nicely. Briefly on the genetic syndromes, Turner syndrome is one of the ones that has an indication for recombinant human growth hormone. Remember, these are kids that can have some of the features shown here: web neck, low set ears, low posterior hairline. They can have a high arch palate. They can have cubitus valgus. They can have bicuspid aortic valve. They can also have the horseshoe kidney. Noonan syndrome resembles some of the features of Turner, but it can happen in both boys and girls. As you guys can see, facial dysmorphism, web neck, and these kids typically will have pulmonary stenosis. Noonan syndrome is another indication for recombinant human growth hormone, so they do tend to be very short if not treated. CHOX mutations, this is a short stature homeobox gene. It's basically a gene that in itself is important for growth. You guys can see on your left hand side the Madelung's deformity that some kids with CHOX mutations can have, which is that kind of like fork appearance of the forearm. It can be part of certain syndromes, especially the Larry-Whale dyschondrosteosis syndrome, so these kids usually have shorter arms and legs. Russell-Silver or Silver-Russell syndrome, these kids have triangular shaped heads, some facial dysmorphism. They can have hemihypertrophy. I don't think you guys can actually see it, but on your right side, the kid has slightly bigger left leg or left lower extremity compared to the right lower extremity. And then Prader-Willi syndrome, which are kids that are basically present with hypotonia, poor feeding, actually struggle to gain weight during the first couple of years of life, and then they actually start transitioning to gaining more weight, a hyperphagic phase, and then these are kids that actually tend to have severe obesity later in childhood. These kids have poor growth, and so typically they are candidates for growth hormone. You do want to rule out severe obstructive apnea on these kids because it's actually a contraindication for use of recombinant human growth hormone on these kiddos. Skeletal dysplasias, just briefly, achondroplasia, hypochondroplasia. So that's why it's important to measure proportionality, because sometimes it actually might be a problem with the skeleton, what is causing the short stature. And just quickly about failure to thrive, is just global decline in growth. It describes a problem, is not a diagnosis. Rarely, honestly, it is related with an endocrine problem, and is usually applied for kids during the first years of life. And it's in general a failure to gain weight. It is described as a weight that is less than the second percentile for gestation-corrected age and sex when plotted on an appropriate growth chart, with decreased velocity of weight gain, and in severe cases, it can also affect linear growth in head circumference. But again, failure to thrive as a concept is a global decline, and it's rarely related with an endocrine problem. You guys probably cannot really see, but this is a list from UpToDate of all the causes of failure to thrive, and I actually went one by one, and the only ones that actually are related with endocrine problems are hyperthyroidism and metabolic problems, including like diabetes, adrenal insufficiency, inborn errors of metabolism. So yes, we're happy to see these kids, but again, just with the kind of like the caveat that most of these kids are probably not going to have an endocrine problem. And that's it. So the next talk is puberty and its disorders, and it's by Dr. Manish Racing.